Hi, my name is Torn. I'm going to be talking to you about breast mass. Let's say, for instance, you find a breast mass in a 46-year-old woman. She comes into your clinic. Initially, you want to assess the need for immediate resuscitation, which likely she doesn't need. You want to take a thorough history of present illness, ask her where she feels this lump at when she first noticed this lump, any changes with the lump throughout time, especially with her menstrual cycle. Can she characterize this lump? Is it painful? Describe the pain. Is the mass tender? Is the mass tender? Is it mobile? Describe the borders. Describe its change. Is it enlarging? Is it shrinking? Is there any induration, drainage, skin discoloration, texture changes, nipple inversion, changes in the gross appearance of the breast, if they're asymmetric. Does she have any constitutional symptoms? Constitutional symptoms indicative of cancer, such as fevers, chills, night sweats, unexpected weight loss, bone pain, jaundice, neurologic deficits, new onset neurologic deficits, anorexia, that goes with weight loss. I want to ask her about a past history of any abnormal breast exams, past history of any mammograms, excision, biopsies of any breast tissue, and what did they find, past history, especially of breast cancer, breast, ovarian, and endometrial cancer, or any other cancers in particular, a trauma to the breast that was recent, past surgical history of any past surgical history of the breast, family history of BRCA 1 and 2, or personal history of that, family history of breast, ovarian, endometrial, prostate cancer, any other cancers, medications. I want to ask her about any past radiation exposure, hormone replacement therapy, oral or other hormonal contraceptives. Even a small bit of chest radiation exposure can increase the patient's risk. I want to ask a thorough social history, smoking, drinking, drug use, especially a gynecologic history. When was her first period? When was her first child born? If she's had any, how many children does she have? How many children does she have? How many pregnancies has she had? Did she breastfeed her children? Is she in menopause or not? When is the age of menopause? Yes. I'm going to move on to a thorough physical examination, specifically focusing on a lymph node assessment, as well as a thorough bimanual bilateral breast exam of all four quadrants, and with the patient in 4 different positions: supine, sitting with arms by their side, behind their back, over their head. And on these bimanual breast exams, extending the reach out into the axilla. I really want to note any skin changes, discoloration, induration, nipple retraction, discharge, characterize the breast lump, see if there's any other lumps in the contralateral breast as a point of reference to find the lump, characterize it if it's solid, rubbery, characterize the borders, rough edges, more lobulated, texture, lobulated texture, if there's nipple retraction, etc. I really want to feel for the axillary, peristernal, superior clavicular, cervical chain lymph nodes. Now I want to move on to imaging that she's 46. I'm going to give her a mammogram, ask her when her last mammogram was, and use this as a point of reference. In this mammogram, ask her if she's a possibility of being pregnant, potentially doing a pregnancy test prior, because you don't want to unnecessarily irradiate a growing fetus. On the mammogram, I'm going to do a mammogram of both breasts, as well, a mammogram of both breasts, as well as a chest x-ray. Based on the mammogram findings, we'll be able to categorize the mass based on the BI-RAD scale 0 through 4. We can follow up in 6 months if it's 4, or if it's a 3 or a 2. If it's a 1 or a 0, we just continue with normally scheduled yearly mammograms. If it's a 3, we would do the repeat mammogram in 6 months. If it's a BI-RAD 4 or 5, these are highly suspicious and highly indicative of a cancerous process, and here we want to move on to a biopsy. I'd prefer a core needle biopsy, as well as X-ray visualization. Visualize the extent of this mass. If there is extensive calcification, this can give us a clue as to the type of cancer, as well as at this point we could think about getting labs of CBC, LFT, etc., in order to assess metastasis potential to these common metastasis sites. Common metastasis sites, I want to get a core needle biopsy, and with the pathology reports, in unison with the X-ray, we can determine the grade and the stage of the tumor, and determine the type of the tumor. There's several types of type of the tumor or type of the mass. What sort of abnormalities present? It could be DCIS, LCIS, sclerosing adenoma, fibrocystic change, intraductal papilloma. Intraductal papilloma could be a ductal hyperplasia, atypical ductal hyperplasia. This could be fibrocystic change, fibroadenoma. So we want to characterize. Pathology will send us a report back. Based on the grade and the stage, let's say that it comes back as a 6 centimeter DCIS mass. Stage 2. Alright. So if this is a stage 2, the stage 2, depending if it's 2A or 2B, this would indicate a large tumor greater than 5 centimeters, and and a possible metastasis to lymph nodes, but we wouldn't be able to figure this out until after we do the dissection. After we do the biopsy. So with the core needle biopsy, we're going to do core needle biopsy, and if that shows wide, multifocal, greater than 5 centimeters mass, DCIS, this indicates a simple mastectomy, and a simple mastectomy is basically a lumpectomy plus axillary lymph node dissection, excision, and Yeah, and you would also give radiotherapy as well at this point. You give radiotherapy as well to help control. Yeah, and the thing you don't. A simple mastectomy. Okay, just kidding. A simple mastectomy does not include. So you do a simple mastectomy, and a simple mastectomy does not include removal of the axillary lymph nodes. What you want to do in this case, of DCIS greater than 5 centimeters, widespread microcalcification, you want to do an intraoperative lymphoscintigraphy, isolate, and biopsy the sentinel lymph node to assess for sentinel metastasis. Now, if there is sentinel metastasis, you want to do a complete lymph node resection, convert this simple mastectomy into a modified radical mastectomy, and that will include, modified radical mastectomy is a simple mastectomy plus the axillary lymph node dissection. And now that you have that, now that you're here, you come to this point, you want to give radiotherapy. You want to look back. From the core needle biopsy. You want to send on the path report. You want to send for hormone receptor status, estrogen, progesterone, HER2/neu. See if the tumor has those receptors. It's conducive to hormonal chemotherapy. Yeah, and so following that, you are. Oh, okay. So once you have the tumor out, okay, just kidding. 5 centimeters of. Okay, so 5 centimeters of the. If it's 5 centimeters more, you want to do a simple mastectomy plus radiation, and simple mastectomy plus radiation, and you assess the form. Simple mastectomy plus radiation. Depending on the form, though, if it's typically, if this is a comedone, a comedo variant of DCIS, then you want to do a complete axillary lymph node dissection. But if this is a cribiform or a micropapillary DCIS form, you don't need to do that. You can just do a sentinel lymph node sample. Yeah, I mean, sentinel lymph node sampling isn't bad anyway, so that's fine. Okay. Now, if this is LCIS, you just follow up in 6 months. Same goes for sclerosing adenosis. However, if it's atypical ductal hyperplasia, you want to do a lumpectomy because this has a approximately 4 to 5 times increased risk of developing into a cancerous lesion. So you want to do a simple lumpectomy. Yeah, simple lumpectomy. All right. Now, what if? Okay, let's say